Hi, welcome to the recording of Fearless at the Vets, Patient Emotional Wellbeing Matters. My name is Dr. Amber Batson. I work in clinical practice and as a behaviourist in the UK, and this presentation is in collaboration with Pet Remedy as part of the London Vet Show 2024. When we think about the emotional well-being of our patients, one of the first questions that we probably need to be just clarifying with ourselves is, what are we actually trying to achieve? Now, this is PowerPoint's image of what a medic might look like, so hopefully we feel reasonably confident that that person may be representative of someone in the veterinary community. We are obviously thinking about making a diagnosis and a treatment plan. That's our main aim. A part of that, though, or the main part of that, is how we are going to make that individual or allow that individual the ability to become better. How are we going to improve their well-being? And of course, sometimes that is treatment focused and sometimes that is preventative focused. But of course, we're also always thinking, aren't we, about fulfilling safety regulations? And that will be for the client who is in the room with their animal, or it might be other veterinary employees who are present. Perhaps it's the nurses or some care assistants or other vets that are around. We also know we want to avoid damage, trauma, further injury to the animal. So are they safe to be on a table? Are they safe to be restrained by an individual? And of course, we cannot deny that we are also having to consider the professional element of our job, which is to generate income as well as promoting positive animal well-being. So lots of that stuff's going on in our head all of the time, of course, when we are carrying out, examinations, interventions with animals and their humans. What about the client? The client obviously has bought their pet to us because, again, they're thinking about their animal's well-being. And again, that might be preventative in some circumstances, or it might be treatment focused in others. They're also thinking about avoiding damage, trauma, further injury to the animal. And we know that a lot of people get really stressed about this concept. A number of studies have shown that a reason many people don't bring their pet to the vets is worrying about how their pet is going to behave at the vet clinic and what the outcome might be for the people around their pet, other animals around their pet, perhaps in the waiting area, and of course also the animal themselves, where people are aware that their animal gets stressed, scared at the vets, even if they don't understand perhaps the possible underlying emotion. What they recognize is their dog is really barky at the vets, really difficult for the vet to examine, then they're less likely to come in. We know that. We have studies that have shown that. And tied in with that, of course, then can be their concern about our safety as the vets or other handlers, other people that are involved, such as nurses and other staff. They're often worried about the judgment that might come as well of their pet's behaviour, even if we don't feel that's coming from us. I think so often in the veterinary community, we're used to seeing scared, frustrated animals, painful animals. But of course, the client doesn't necessarily see that with the same frequency or intensity that we do. And therefore, they're really concerned about the outcome for their pet and those around them. And that might mean that they really feel judged because, gosh, it is only my animal that behaves like this, isn't it? And of course, the client is often, as we well know, concerned about potential costs. And that might mean, and we'll come back to this later, that sometimes they're worried about bringing the animal back repeatedly. And that cost can be financial, but of course, cost isn't always about finance. Cost is also about other resources, and other resources include their time. So they may well be not worried about the financial cost of coming back to the clinic for a repeated visit, but they might be concerned about the availability of their transport, or they might be concerned about how that's going to impact on taking the children to school, looking after parents, other individuals they care for, etc. So that's always going through our clients' minds, as I think we know, but sometimes in the moment, it might be a feature that might crop up if the client's starting to think, oh gosh, will I have the time, the resources, the costs to come back if they're unable to do this procedure today? What about the dog? And this presentation is focused on dogs rather than other animals in the veterinary clinic. But obviously, a lot of these principles will apply to a wide variety of species. Our animal patient really just wants to feel safe. That's the important thing from their perspective. They don't appreciate that they're coming to the vets for us to undertake preventative healthcare or to alleviate their pain, because from an evolutionary perspective, that's not what another species would do for them. And although, of course, they've learned to have a relationship with us as another species, and they can get, of course, reassurance from us, understanding that nuance of, well, this medical individual is here to medically help me get better, is just not something that they're likely to have the cognitive capacity to understand. And therefore, in our attempts to examine them, to undertake procedures, it may well feel for some individuals that we are not a safe individual to be around. So they're also motivated by avoiding damage, trauma, further injury to themselves. And that might mean that they use a variety of communications or actions to try to stop us doing some of the things that they perceive are a problem for them. Do they have the ability to understand that this is going to help them recover from injury or illness? Do they have the ability to understand we are there to reduce, eliminate pain, or other restrictions they may have? Well, probably not. So when we look at it from the dog's perspective, the dog wants to feel safe. The dog wants to avoid damage, further injury to themselves. It's important that we as the clinician are able to take some time, which is why you're listening, I'm sure, to this presentation, but also in the moments as well, to just stop and observe what the dog is offering and use that observation to recognize the internal experiences that the dog is having. Some of that will be emotional. Maybe the dog is feeling fearful. Maybe the dog is feeling frustrated. Maybe some of that is sensations, that this is a hot sensation, a cold sensation, an uncomfortable pressure sensation, a stabbing pain sensation. And if we are able to observe and think about that lived experience for the dog in that moment, then that will always improve the safety of our handling and will also assist our decision making. That helps the humans that are involved because it keeps us and the veterinary staff around us and that animal safer, but also it helps the dog feel safer too. I a governor for primary schools, and in one of the schools that I work for, we have a motto. We have a motto that is for the children: always be thinking about be ready, be respectful, and be safe. And I think that's a really great motto actually to apply in veterinary practice. What have we done to get ourselves and the patient ready? And that's something that we really are going to explore a little bit more, and is also a big part of the emotional well-being initiative that Pet Remedy are now developing and going to be presenting as a result, following on from this conference. What can we do to prepare? Have we got a plan? What's our plan if things go wrong? Respectful. How can we undertake the most empathetic handling for the animal's benefit, for our own benefit, and for the human caregivers associated with that animal as well? And of course, tied in with all of that, therefore, is how safe are we? How physically safe are we? But also how emotionally safe are we? And when I say are we, I mean the animal as well as the humans. When we think about those observations, I mean, this is a big topic in its own right. So I'm going to have some little pointers in terms of some references, but also there will be additional resources available through the emotional well-being web page that we will be launching to think about how do we understand those communications. Dogs give off a lot of communication using their body language. And a lot of what we see, particularly when we're having direct physical interactions with dogs, will be appeasement signals, or sometimes they are referred to as calming signals. So these are things like turning the head away, lip licking, nose licking, lifting the paw, wagging the tail, sometimes yawning. There's a whole variety of appeasement signals. And appeasement, of course, meaning, are you going to hurt me? I don't mean any harm. Please don't. If we see appeasement signals like head turning, lip licking, paw lifting, tail wagging, and they're happening at the same time as the dog having quite confident, relaxed body postures, fairly like the animated image on the right hand side is currently in a static position of, which is ears are likely to be more forward, the weight is evenly distributed through the body, the muscles are soft, the facial features are soft, the tail is loose. Then when we see appeasement signals of a head turn and a lip lick at that moment, then it's more a question from the dog, it seems, that I'm okay. Are you okay? So it's a check-in. Just like we might approach somebody we're not that familiar with in the supermarket with a soft smile. I think I'm all right here. Are you okay if I walk past you in close proximity? Where we see those same signals of a head turn, a nose lick, a yawn, a tail wag, and the body is tense, it's in more fear related body postures. So there will be, the ears will be drawn back a bit more, the facial features will be tight, there will be more tension through the body, the tail's going to be more rigid. Then that combination of body position and tension with appeasement signals takes the conversation now towards, I'm not okay. Are you okay? Which is more a, please don't hurt me. I don't want to hurt you. So what we can sort of think about is when we're making our observations in the waiting room or in the consulting room or out in our hospital ward area, what is the volume of this dog's conversation with us? Are they able to have a conversation which is somewhere between whispering and talking? Or are they having to shout or even scream to get their point across? Because when we see appeasement signals being used with confident, relaxed body postures and perhaps just intermittent hints of more tension, perhaps some increased frequency of appeasement signals, then that's normal in a fairly unfamiliar setting where people are trying to touch you and physically interact with you. And that is that dog having a talking conversation where they're moving between, well, I think I'm all right about this, or towards, I'm not sure I'm okay with this. Where we start to see dogs go still, go more rigid, they are on the cusp then of growling. Perhaps they're actually snarling or snapping or barking. Then we've definitely moved into the realms of them feeling the need to shout or scream their intention. I'm really not okay. Stop. Leave me alone. So, a publication from Martin in 2023 looked at the fear, anxiety, stress, FAS scale that can be applied to dogs. And I'm not going to go through this in substantial detail because you can read it there. And also, you'll be able to then to come back and look at this slide. But it's really just to highlight the fact of a perhaps fairly simple version of what we can do when we're making observations about dogs in the consultation or examination process is to try to put them into the green, amber, red zones, where green would be just like our traffic lights, that we're okay to keep going. Yeah. Whereas amber, perhaps we should be getting ready now to think about pausing. And if we're red, then we definitely should be moving towards stop. So falling into the green, and I have adapted this scale very slightly, just more sort of for clinical ease in a way. When we are in the green, the sorts of things that we're seeing are a really relaxed dog, soft eyes, soft face, body loose. And there may be a few appeasement actions like some tail wagging, the occasional lip licks and blinking, but the dog is choosing to interact. That's a green light. And I think we're all very well aware of that. Another green light would be, well, perhaps there's a few more appeasement actions, but still the body is loose, the tail is still fairly loose in its wag. But again, the dog is choosing, if we pause, to interact with us in some way. Amber starts to move into that increased tension that we were just referring to. So now these individuals are more tense in their muscles, they're showing more appeasement actions. Often the dog might also start to pant, and we see shifts in the tail position. In clinical practice, that tends to be the top of the tail pulling itself down quite tightly as that increased tension develops. Another amber, which is getting a little bit more, well, no, if we're seeing this, we really need to be thinking about, or, getting ready to stop, if not already stopping, is increased tension. Those ears are going to come back further. And we might even be getting some short freeze responses mixed with more frequent appeasements. I'll go very still for a bit, and then I'll do a lot of lip licking or some quite frantic tail wagging, and that tail starting to come more actively down. By the time we are seeing very avoidant body language, so the dog is often looking fully in the opposite direction. They might be providing whale eye where we're seeing the sclera, or maybe they're even keeping their eyes specifically quite closely closed. Everything's got tense in the body. They might be trembling. Their facial features are moving like they're about to start lip curling. Then we've moved into the red, and we really should be thinking about stopping in that moment. By the time we're seeing tight body language all over, growling is very likely to be present, or barking or snapping or biting, well, hopefully we had already recognized we should have stopped earlier. 6 are dogs where we didn't even really get that far. We're unable to be in proximity safely because the dog is from a distance snarling, lunging, and trying to bite. So I think if we think about that traffic light system using that FAS scale, that can really help us. And I think that's sometimes a really good way as well of having something on a clinical record. We'll talk towards the end of the presentation about the possible use of pre-appointment or pre-examination medications. And it's useful to know what the response to those has been and to be able to record that. So our colleagues in the future can look at the notes and go, oh, that did work well, or that didn't work well, if we're not around to be part of that particular assessment. So when we're making these observations, it's very easy for us just to start talking about what we're seeing and putting quite often a strong human bias on what we are observing. A lot of the time, words that we use to describe animal behavior is highly anthropomorphic and sometimes anthropocentric as well. Why do we do that? Well, because, that is sometimes what we've been conditioned to do. It might be part of our culture. It might be part of our personal upbringing. And sometimes it might just be our sort of our own coping strategy as well. So questions that we might want to ask ourselves is, how often do we actually refer to our patient as they, or him or her, when we of course know their biological sex, rather than it? Because when we use the term it, that is actually, in a way, depersonalization. They're not inanimate objects, they are sentient beings. And I feel that the more we use words that reflect them being sentient beings, the more that just taps into our brain to be thinking about the emotional well-being of that patient. Other things that we all do is refer to the behavior as it being a good behavior or a bad behavior. And sometimes that even then becomes a description of that individual dog. They were a good dog in the clinic today, they were a bad dog in the clinic today. And we'll come back to this shortly. But of course, a dog who is using distance increasing actions like tension and perhaps trying to escape, moving away, or even trying to get us to move away by growling or even snapping isn't a bad dog. They're just communicating. And what opportunities did we give them, as we've already said, to communicate in a way that is a whisper to a normal level of conversation rather than having to escalate up to shouting? They're not intentionally being naughty. They're not intentionally being dominant. They are just using body language and actions to communicate how they are feeling and what they would like to happen in that situation. So, always the best in many circumstances to try to describe the behavior we see and leave it at that rather than try to give it a label. So, as an example, something that I might have said in the past, and I've certainly heard many colleagues say in the past, was, oh, it was so badly behaved for the blood sample today. Whereas actually, we could rephrase that and we could say she or they repeatedly attempted flight when her leg was restrained for us to put in the needle. We're using now a descriptive term of what we saw. Because also, actually, that's really helpful if we make a comment like that within a clinical record, because then we know what that dog's preference had been in that moment as their communication or avoidant behavior attempt. If we just say they were badly behaved, that doesn't tell me whether the dog actually was a bite threat or whether the individual was a panic attack threat, trying to throw themselves out of the room, or what else might have been my interpretation of badly behaved. So trying to be just simplistically descriptive about what actually happened rather than labeling can be a really helpful thing. Compassionate and empathetic handling is always more likely to occur when we repeatedly acknowledge and remind ourselves and our colleagues that these animals are highly sentient beings. And I know we know that, but in the moment, we can sometimes become quite task orientated rather than being patient focused. So when we think about what might be driving some of these distance increasing signals, communications from dogs in our clinic setting, we can perhaps divide into two separate categories. We can have individuals who've arrived in the clinic today who are in the moment scared, perhaps frustrated, and or in pain or other forms of discomfort. So in the moment, the dog is thinking, oh, I've never been here before, or I've never met this particular human before. So maybe that is scary for them. I've never been restrained like this before. This is frustrating. I don't know how to get out of this. Maybe that's also scary. Maybe it's uncomfortable. And then, of course, there are a number of patients who come to us who are arriving in pain because they have an ear infection or a wound or a lameness or a sore abdomen. And so, of course, I'm already in discomfort or pain. And that is my lived experience right now. And that's in comparison to dogs who have made associations because of previous visits. And sometimes it is visits to us as a a specific clinic. Sometimes it is visits to us as a specific individual vet. Maybe sometimes it's happened in another clinic setting. And maybe, of course, it's something that has actually happened that isn't specifically veterinary, but is about touch-based interactions. So perhaps if 2 or 3 weeks ago the dog had their first grooming experience and that grooming experience didn't go very well, or perhaps they were microchipped as a puppy, whether it was in a veterinary environment or by a designated qualified individual, that perhaps they found that very painful or uncomfortable. So we get dogs who are coming in who've got previous associations with certain touch-based interactions where they're being carried out by unfamiliar people. And we also might have dogs who have associated coming into somewhere like the vets with being in proximity to unfamiliar dogs or being in proximity to other stressed or highly reactive other dogs. Because, of course, dogs are assessing their environment using their nose a lot, and they're picking up on a whole variety of odours, some of which also can have pheromonal activity. And they're much better at that than we could ever be. So they may well be picking up on the stress signalling, or even pain or unwell signalling that's coming from other dogs within the clinic. They may have had negative experiences with other dogs away from the practice. Maybe they were attacked at the park when they were 6 months old. Maybe they actually were threatened by another dog just this very the morning before they came into the practice. Previous experiences they've had within a clinic setting, within a husbandry type setting, or even some other aspects of their lives can come as memories into the clinic. And so those learnt responses are already being exhibited before we've even done the thing that we might want to do. We tend to talk about in the moment experiences. This is new and worrying to me right now as a fairly new experience in relation to sensitization. The dog is sensitized, they've got rising stress levels, accompanying internal physiology, and therefore actions are being carried out because of that internal physiological response. And the body and brain's reason for doing that is to attempt to help that individual to remove themselves from that situation or find at least some form of relief. When we think about previous situations, so they're coming into a veterinary clinic environment with a learnt association from something that's happened before, then we refer to that as a conditioned response. Many of us will, of course, remember Pavlov from somewhere in our previous learning, Ivan Pavlov, the Russian physiologist, who did that experiment where he didn't really ring a bell, but it was actually a metronome in terms of timing of music, tick tock, tick tock. And he made that neutral sound and then paired that with giving the dogs food. And by a number of pairings of tick tock, and food, tick tock, food, he ended up being able to just do the tick tock element without the food, and yet the dog still salivated. And we get that type of conditioned response in dogs where they have fear experiences, frustration experiences, and certainly where they have pain and other discomfort experiences as well. That means that, again, they're already coming into the consult room, they're already perhaps in the hospital setting with elevated stress levels and already offering behaviours which are being driven by those stress levels or internal emotional responses. And they're going to be involuntarily, unconsciously offering behaviours before we've even done some of the things we want. We're all familiar with that, aren't we? We do a blood sample on a dog. The dog's had blood samples in the past. We just go to clip the patch over their jugular, and already the dog is jumping up and down on the table. Now, that specific response could be they've never met clippers before. And if they've never met clippers before, having that noisy, vibrating thing against your neck puts them in the left-hand category. This is new, potentially scary. I don't understand what's going on. Whereas for some dogs, the sound of the clippers is has been made through an association. It's a precursor to what they know is going to follow of restraint and the needle going in.